Thank you so much for the opportunity to speak. I'm also a very fast speaker, and I want to try to give you the most interesting information and updates in terms of the world of gonorrhea. There's so much going on at this point, so I'll try to keep it as short as I can. My conflicts really have nothing to do with this talk. What I'm going to do is talk a little bit about the epidemiology and really talk about the epidemiology in North America, screening, and some new clinical manifestations that are resurging, especially where I am in the South, antimicrobial resistance challenges, and then what do we need to do for treatment optimization. So this is just looking globally, and I just wanted to show these global slides from the WHO comparing chlamydia, gonorrhea, trich, and syphilis. And even though the rates aren't particularly high compared to other STIs, including chlamydia and trichomonas, I think the treatment-related implications of this infection are just vast. Here in the United States, gonorrhea is actually the second most reportable disease to the CDC. And looking again at some just very quick epi about what's going on, and I think some of these same trends are happening around the world, but just wanted to share some of the preliminary data from 2017. And this is looking for the past 5 years that rates of gonorrhea have increased 112% and 40% respectively in males and females. It's occurring in all age groups, but most commonly in 20 to 24 years old. There continues to be a disparity in terms of race, although that has decreased in the past number of years. And as with all the other STDs, the South seems to be the area with the highest incidence of STIs, especially in gonorrhea. So I want to share with you a little bit of some data that CDC is doing in terms of looking at the surveillance. There's an STD surveillance network, otherwise called the SUN. And so when you see some slides, these are called SUN slides, and these are from 10 to 12 health departments, and they actually look at both facility components as well as population components, risk behaviors, including interview and clinical behaviors, and then things that you may be familiar with, which is the gonococcal isolate surveillance project, a surveillance project that has been going on since the mid-'80s, looking at gonococcal antimicrobial susceptibility trends, and it looks currently at 27 STD clinics from around the country, where it surveys 25 men urethral isolates per month from all these 27 sites. And we'll talk to that when we look at some of the data from the antimicrobial resistance. And this is just looking at the first surveillance data, which is SUN, which is really interesting, looking at different cities where we're seeing the gonorrhea. And you see MSM, men who have sex with women, and women. And you look at the difference in the cities, and you see the vast difference looking from San Francisco on your left to Baltimore on your right, looking at the difference. So all these different cities here in the U.S. have really different incidents in terms of which risk group you're looking at in terms of gonorrhea. Looking again at SUN data since 2010, the reported rate of gonorrhea amongst MSM has increased 151% compared to 40% increase among females. So not only does CDC have the epidemiologic data, but using these other surveillance data sets, it can kind of help stratify the MSM versus MSW. Then again, looking at SUN data, and this is the most recent data that CDC has from 2016 showing the difference. I list here the syphilis data compared to GC and CT, and looking at the difference between HIV positive and negative, and looking at all these STDs that they're more common in individuals with HIV infection. So that's a little bit about the epi, and let me talk a little bit about the screening and then what we're seeing in terms of the clinical manifestations. So these are the current STI screening recommendations from the U.S. Public Health Service, looking at heterosexual men and women. The recommendations for gonorrhea screening are annual screening for women less than 25 years or older with risk factors. And then the important recommendation to retest after treatment because of the high risk of reinfection, about 15%. And then among men who have sex with men, the recommendation for site-specific screening, and then at least yearly screening dependent on risk, and these are based on the STD treatment guidelines. And when the U.S. Public Service Task Force looked at this same information in MSM, they list in their guidance that there's limited evidence to evaluate individual benefits. Few studies have evaluated the impact of extragenital screening. But what about the effectiveness of STD screening? We think we need to think of both at the individual level and the population level. The benefits in women include reproductive tract sequelae, an MSM reduction of complications, HIV acquisition, and it's also an opportunity to get people in for prevention services such as substance abuse, mental health services, and PrEP. The benefits on a population basis don't have as much, more limited data here, but to screen and treat an asymptomatic extragenital infection to reduce ongoing transmission. The nice talk we had earlier about the oral transmission, in particular of gonorrhea, and the pharynx, not only as a reservoir, but also as a reservoir for antimicrobial resistance. And then, as I mentioned before, the limited evidence of a population benefit in MSM. Should the focus be on individual versus population-based benefits of screening? And I list an article that's in Press and a nice editorial there that goes over these population versus individual benefits of screening. And then also these studies, which you probably can't see, but I think these are important studies from a couple of years ago that says not only do we need to think about individual risk factors, but also the importance of sexual networks, social determinants, neighborhood factors may supersede individual risk factor benefits. In particular of the psychological trauma that somebody may have developed early in life and how their current living situation may impact incidence of STIs. So in terms of the clinical manifestations, I'm not going to show you as many pretty pictures because there's not as pretty pictures of drips as Ned had of the nice ulcers. But in particular, the many different manifestations in men and women, urethra, epididymis, pharynx, rectum. As you know, most of the infections at the pharynx and the rectum can be asymptomatic. What I wanted to spend most of the time talking about really is what I've seen an increasing amount of, and that's disseminated gonorrhea. But before we get there in terms of the testing, this is just a recent paper a number of years ago that looked at if we just ask for not take site-specific screening, and we just ask men to urinate in a cup and not do site-specific screening, the percentage of infections that we will miss of gonorrhea and chlamydia. And then another recent study looking at the prevalence of rectal GC, this is asymptomatic infection, and actually showing a high prevalence in non-sexual health clinics. And the prevalence was very wide, but it was more common in individuals that went to clinics that weren't specifically dedicated to sexual health. So I want to spend a little bit time on disseminated gonorrhea because in the last 6 months, I usually see about 1 case per year. I've had 6 cases of disseminated gonorrhea, and I just want to bring this up again to raise this up for people to think about for the clinical presentation. Some of this data is really old, estimated to occur in about 0.5 to 3% of all gonorrhea infections. The older risk factors told us about it was more common in women, in pregnancy, and those that had terminal complement deficiencies. And the 2 major ways that these patients present are either monoarticular septic arthritis or a tenosynovitis dermatitis syndrome. Although also in the literature has been described perihepatitis, endocarditis, and meningitis. So it's generally a clinical diagnosis. You make the diagnosis based on the patient's clinical situation, and the yield from a throat or a synovial fluid or a pustule is very uncommon in terms of getting a yield from those cultures. It's much more common to do mucosal site sampling. This was an important paper that was done a couple of years ago and looked at the decrease in disseminated gonorrhea, especially in women, comparing some data from the United States and Texas. However, we don't have really good surveillance data in terms of what's happening with DGI. And this was mirroring the data that is available versus when some of these investigators looked at what was going on in Texas. And when they looked at a comparison between their women that were pregnant and non-pregnant, found a difference in terms of their age and whether infections were proven, probable, or possible. And those of you that make diagnoses of DGI know that most of our diagnoses are usually made as possible diagnosis, a clinical diagnosis plus either an antimicrobial response or a presence of the organism at a mucosal site. And then in terms of the differences between pregnancy and non-pregnancy, you'll see there that the pregnant women tended to present in a shorter duration of time and were less likely to have any positive cultures. And I just wanted to show you an example. I saw this patient actually this year. She was a patient that was 23 years old, was a Gravida4 Para 1. She was 21 weeks pregnant. She presented with right ankle swelling and pain. You can see that ankle, it's pretty dramatic. And she also, when you talk to her, she also had a history of migratory polyarthralgias. The OB docs were concerned about her ankle, so they did an MRI, which showed osteomyelitis, and she was whisked off to surgery. We were called as infectious disease consultants because she was allergic to penicillin. They had gotten, as part of her pregnancy screen, a urine GC NAT, but didn't put the two together, that she had disseminated gonorrhea. And so I'm just pointing this out because I have seen, like I said, a resurgence in the past 6 months, and 3 of the patients had shoulder arthritis. And so I want to raise the awareness of this in particular. And then there was this interesting article that came out from France a couple of years ago that basically showed in France through this paper that the epidemiology with which we once learned was changing, and that it wasn't young pregnant women. It was occurring more in men, and we were seeing it in men who have sex with men in terms of the same clinical presentation, but again, bringing up the changing epidemiology of DGI. So because of this, I discussed with some folks at the CDC who decided to go on to an existing surveillance system that they have and start looking to see how often we're seeing this, because we have no good denominator data in terms of this. And the premise of this was to describe the epidemiology by looking at a retrospective cases as well as from 2017 on, looking at prospective cases, and then to grab these isolates and to use current techniques like whole genome sequencing to look at these and see if these are similar to what the isolates looked at 30 years ago, because no one's ever really done that. So this is where we are at this point. There's 26 patients, and this is done in a surveillance area looking at the metropolitan Atlanta area as well as California, and we have 26 cases within 2 years. The demographics are 42% female, men who have sex with women 15%, and then males of unknown sex partner 38%. And the other interesting thing is that 30% of these patients are over the age of 45, which is very different from the older literature. The clinical syndromes are very similar. Most of these patients have no underlying risk factors. And so, again, I'm pointing this out because we're seeing it, and this presentation, I think we need to really start thinking again about. Also wanted to point out about, you've heard about the use of eculizumab and its increased risk of invasive meningococcal infections. There's also case reports in patients that have disseminated gonorrhea. And there's an ongoing analysis from the FDA of 9 ongoing cases of disseminated gonorrhea. So next we want to move to antimicrobial resistance challenges. I mentioned before the surveillance system that CDC has since 1986, looking at trends in antimicrobial resistance testing. And these kind of trends are what CDC uses this data to help drive treatment recommendations. And what you can see here is the continued high prevalence of resistance to tetracycline and penicillin, although we haven't used them in decades. And even though ciprofloxacin was not recommended for several years, its prevalence continues to go up. But what I really want to concentrate on is the increase we're seeing in azithromycin-related MICs, and the ceftriaxone-related MICs are relatively flat. So this is putting all this data together since 2006, looking at the ceftriaxone MICs in blue, cefixime in green, and the azithromycin MICs, which you see there in red. So since 2013, there's been a progressive increase in the rise of azithromycin MICs. And if we stratify this by MSM versus MSW, you'll see it's about 7% in MSM, looking at this preliminary data. However, most of these isolates, if they're not high-level resistant, they're low-level resistant with MICs, generally around 2. And in Amenuev in sex with women, it's about 30%, although if you stratify and look around the country, there's actually pockets in the country where it's much more common in Amenuev sex with women. This is, again, looking at the azithromycin and cefixime lines, and you can see the trend over time. There's a rising proportion of cases. Decreased susceptibility to cefixime remains very uncommon, as was shown in the previous graph. This is looking at the current recommended treatment in the United States. There is no overlap between isolates with resistance to ceftriaxone or azithromycin. So because of this, and this was part in the U.S., the President's initiative to look at not only GC, but a White House plan to look at antibiotic-resistant bacteria and advanced molecular detection. GC is part of this, and the thought is to strengthen surveillance in North America, building on the existing surveillance program that CDC has through GISP and SUN. The creation of regional laboratory reference networks, strengthening response to resistant gonorrhea, and looking at the economic impact of resistance. So in terms of treatment, gonorrhea, what I list down here for you is the current published treatment recommendations for the U.S., United Kingdom, Europe, and Japan, and you'll see there are differences. Thinking about this for all of us going forward, what I've been really struck with is what we really don't know about these antimicrobials in terms of some of the sites of infection, in particular the nice talk we had earlier about pharyngeal infection. And do we really know really well looking at the different antibiotics that we're using, concentration dependent versus independent, the use of PK and PD? What do we really know about how long the ceftriaxone stays in the pharynx? Thinking about patients that come in and get dual therapy, they may not get their azithromycin on the same day they get their ceftriaxone. And knowing that the ceftriaxone half-life is short and the azithromycin monotherapy, they're pretty much getting azithromycin monotherapy if they're not given it at the same time or on the same day. What about the bacterial burden of infection? Does that make a difference? Mutational frequency to resistance. Resistance suppressive targets, even if you identify them, does not guarantee eradication. We have 2 new novel agents, 2 phase 2 trials. Looking at these agents, and the phase 3 trials are ready to be undergone. We have the report of treatment failures looking at these current regimens. Dual therapy in the UK in March of this year, a GC isolate both in the UK and 2 in Australia with MICs of 0.5 to ceftriaxone, azithromycin of greater than 2 to 256. And then how are we going to use this? This was a really elegant study done by Harris looking at genotypic antimicrobial resistance studies, where they combined the use of whole genome sequencing in conjunction with epidemiologic and phenotypic data. And to try to understand the distribution of resistance clades, and wondering about these markers that we talked about before. Are there particular markers that we can use in particular populations of people? And then the last to just deal with, this has been noticed again at the global level, and there's a global antibiotic research and development partnership launched by WHO and Drugs for Neglected Disease Initiative in 2016. There's a draft of an acceptable target product profiles that was developed and a timeline. And this research and development plan has 4 goals: accelerate the development of a new clinical entity, to evaluate the potential of existing antimicrobials, to explore co-packaging and fixed-dose combinations, and to develop more simplified treatment guidelines. And this is just an example of some of the short and long-term goals that you can find in this report that was developed through a gonorrhea consensus expert group. And then the last thing to just think about, to just pique your interest, is you may have heard about this cross-protection from a meningococcus vaccine, the outer membrane meningococcal group B vaccine, where there's a homology between the 2 organisms, and the question of some cross-protection between this vaccine and gonorrhea. So the last thing to just talk about then is putting this all together. So what do we need in terms of going forward? We talked about the global epidemiology, the need to partner with other countries in terms of enhancing our international surveillance, the screening of populations at risk of infection, in particular at sites where the infection has no symptoms, the variable role of the clinical presentation and the increase in terms of disseminated gonorrhea, the role of extragenital infection. Other things to think about: partner services. What about the role of getting other partners in, and some of the health departments that are really strapped in terms of making decisions about who should get in for partner services? The social determinants of health, not only individual risk, but also population-based risk. And then effective treatment, combination therapy, the role of PK/PD, the site of infection, antimicrobial stewardship in terms of the treatment of gonorrhea, the novel therapeutics, and the GARP initiative, which I mentioned to you. So thank you so much for your attention.